reaction, lupus or lupus tumidus. In the European countries, justness infiltrate. Ruptured cysts can cause an exuberant pseudolymphoma folliculitis, reaction to foreign bodies, tattoos, vaccinations, acupunctures, infections can mimic. Lyme disease is predominant in causes lymphoma in Europe. I haven't seen it really here in this country, although I check regularly Lyme titers. And then others, halonevus with an exuberant lymphocytic reaction. Sometimes these follicles you can consider angiolymphroid hyperplasia with eosinophilia or Kimura's disease. So what are the clues favoring lymphoid hyperplasia? And I think Victor Greta will go into details, but I've just mentioned briefly top heavy infiltrate, polymorphous infiltrate, positive intermediate-sized cells. You see prominent vein mills and fibrosis, and you do see also lack of light chain restriction. But you do find, you can find a lot of germinal centers, but also those patients do have generally lack of recurrence of disease. This is just a snapshot of a benign reactive infiltrate. You see lots of small lymphocytes. You do see plasma cells and histiocytes within the infiltrates. A band-like or perivascular pattern is more associated with photosensitivity medications, idiopathic conjunctivitis, and clinically can resemble mycosis fungoides. Just want to point out, I see a lot of cases that have been initially referred as lupus or justness infiltrate, but this is a T-cell infiltrate, but the patchy pattern may really mimic a B-cell lymphoma. So this is the WHO EORTC classification on B-cell lymphomas, and these, the most common indolent types is marginal zone B-cell lymphoma and the cutaneous follicular center cell lymphoma. The intermediate type, the most common is really the diffuse large B-cell type, LEG type. Then the other types, it's very rare. The T-cell, histiocytic rich large B-cell lymphoma and intravascular large B-cell lymphoma is still a provisional entity, but this is really primary cutaneous. So the classification, actually, the EORTC, you can is similar to the WHO. They're both classified as follicular center cell lymphoma, marginal zone lymphoma, previously immunocytoma, or includes the patients with immunocytomas. The WHO, it's really all the cutaneous are classified as extranodal marginal zone B-cell lymphomas. Intermediate type, this is the large B-cell lymphoma of the leg type. However, in the WHO, it includes cases of follicular lymphomas and the diffuse large B-cell lymphoma. Provisional is really the intravascular large B-cell lymphoma. So cutaneous marginal zone lymphoma has some overlap with cutaneous plasmacytoma because of a lot of plasma cells you find sometimes in the infiltrate. These lesions can be solitary or multiple like papules, plaques, nodules. In Europe, it's association with Borrelia ciliae. Frequent relapses. They rarely present with extracutaneous dissemination. The phenotype is usually that CD20 positive, also CD79 is positive, negative for CD5, negative for CD10, BCL6, but positive for BCL2. And usually the plasma cells are positive among one, and you can quite get a strong reaction if you have a lot of plasma cells. You do find transformation into diffuse large B-cell lymphoma, but it happens rarely, and heavy chain rearrangements is found by molecular testing. The relapse rate across publications is really high. It's 40 to 45%, but excellent overall survival. The 5-year survival is over 95%. In my next lecture, I will get into therapy, but briefly, you can even observe those patients. You don't necessarily need to treat them right away. These are the clinical features. If you find this is in multiple papules, actually coalesced into a plaques. This is typical findings with patchy infiltrate, periapnexal in the superficial and deep dermis. There's no angiodestruction or any follicular destruction. You find those cells are pretty small and almost inconspicuous. This is another patient. You find here this patient is lambda restricted, covers negative. So there's a high incidence of GI disorders and autoimmunity in those cutaneous marginal zone lymphomas. So Johan Guitart from Northwestern, he actually looked into his patient population, found that over 60% in his patient population have GI problems. Also autoimmunity is pretty high, 20% of the patients. Hashimoto thyroiditis, ANA, lupus, and Sjogren's were the most common types mentioned. So can we clinically make a distinction between a primary cutaneous and a secondary? Of course, just by the clinical exam we cannot, but there are certain areas so that may be more prone for primary cutaneous lymphomas as opposed to secondary cutaneous lymphomas. This is also a study by Johan Guitart, who looked into those patients, found that most commonly the primary cutaneous marginal zone lymphomas are on the extremities and trunks, while the secondary secondary to the skin are mainly on the head and face area. So I just want to mention CLL can commonly involve the skin, as we all know, and when you do a biopsy on those CLL patients and do not know the history, you may really diagnose the cutaneous involvement as the marginal zone, as those cases present similarly with these kind of red follicle centers and invaded by these small cells. Analysis from Stanford actually looked into differences between primary cutaneous marginal zone lymphoma and CLL, found they're really morphologically similar, and you can use the diagnosis because they can present clinical in the same way. They do present with light chain restriction. They do present with a lot of plasma cells. So the only thing you have to consider CD5 stain, which is positive in CLL and negative in marginal zone, as well as CD43. So cutaneous plasmacytoma is very rare. This can be primary is very rare, or it can spread actually from the bone as part of a disease of multiple myeloma. Studies have shown that extraosseous lesions are more common with IgD secreting tumors. You do find a monotypic infiltrate of plasma cells. They're all CD20 negative. Those cells can look atypical, but can sometimes look pretty bland. So the main differential diagnosis is really immunocytoma or marginal zone lymphoma with a lot of plasma cells. Here, this is basically a uniform population of plasma cells. I want to point out, and I have seen 2 patients I found who were referred for B-cell lymphoma, but this patient had actually syphilis. You do find on Roderick state these are the spirochetes, so you still have to consider syphilis. So in all my patients, I check actually RPR. So cutaneous plasmacytosis is a very rare disease, most commonly in Asian patients, actually most commonly in Japanese patients. This is a Japanese patient who presented with these progressing cutaneous papules over 10, 15 years. And the etiology is not known, but it's assumed that interleukin-6 in the skin actually is a factor that attracts the plasma cells. When you do a biopsy, you find mature plasma cells predominantly localized around blood vessels. And they're polytypic, so you do not find any IgH restriction, or light or heavy chain restriction. So the primary cutaneous follicle center cell lymphoma is the most common cutaneous B-cell lymphoma. Most patients present present with a lesion on the head and face. So in contrast to marginal zone, they're all CD20 positive, but they are CD10 positive, BCL2 positive, and if it's primary cutaneous, it should be BCL2 negative. But cases with BCL2 expression have been reported. They also show one negative type. So the cutaneous relapses are also common, and when we go into detail later in the treatment, that helps actually planning a treatment. So you need to avoid over-treatment in those patients. So again, as I said, BCL2 is negative. That basically means it's no translocation for 1418. This is a patient of mine who had presented with a facial lesion. You can see the whole cheek is involved here and here. So predominantly find a dense infiltrate. This is actually a reminiscent here of a follicle. It's a germinal center here, predominantly of centrocytes, a few centroblasts. This is another patient of mine who has really heavy infiltrate. We do find, that, again, as I mentioned, follicular structures, generally more centrocytes and centroblasts. In systemic lymphomas, you do grade the lymphomas. We don't, in primary cutaneous, we generally actually, I try to avoid grading because this causes a lot of confusion among the oncologists, so they feel like if I say type grade, then they have to treat the patient more aggressively with chemotherapy. However, primary cutaneous has still a good prognosis regardless of the grade, whether it's grade 1 or grade 3. And the grading is really based on how many large cell centroblasts you find in the infiltrate. But I think Dr. Prieto will go into more details. So this is actually a patient who presented actually with a BCL2 expression in the infiltrate. This is another patient on the scalp presenting with more defined plaque here at the forehead. It's very common. It's very common in the elderly patient. So when we have to worry, really, we do need to do staging, but multiple lesions may point out to more aggressive disease. You see large and deep nodules. You see more the large cell morphology in the BCL2 expression. It's generally in the older patient, but if the patients are really 8 years and older, we still more worried. This is another patient, more diffuse. The whole forehead and scalp was involved. This is a patient with a large nodule. He had other nodules on the trunk. So staging actually revealed that this patient had disseminated disease, and it turned out that this patient had actually a secondary involvement of the skin. So the most common diffuse large B-cell lymphoma type in the skin is the leg type. It's more like in females and in males. So the phenotype is can express BCL2, can express BCL2 or can be negative. Is negative for CD10, can be positive for BCL6 or be negative, but it's MUM1 positive, and many show also FOXP1 positivity. Generally, no translocation found. There are frequent cutaneous relapses. Extracutaneous dissemination is more common in this type, and hence more aggressive. The 5-year survival is 50%. Those patients generally require a more aggressive approach. This is an example of a patient with a large ulcerated plaque in this infiltrate, dense infiltrate of this large, more large centroblast. You find many of them express MUM1. It's a close follow-up on this patient again. So there's another patient with multiple lesions on bilateral legs. So the leg type can present on other areas. It's most commonly on the leg. However, I have seen patients on the back and trunk as well. So in essence, you have to, by immunophenotyping, then really tickle out the type, whether it fits into the leg type or in the other large B-cell lymphoma groups, which is